What's up, Rickies? Welcome back to Rotation Ready, your pharmacy rotation curriculum. We're working through all 9 domains of pharmacy rotations, backed by over 1,200 real preceptor observations I have collected over my 10 years of experience as a clinical pharmacist and as a pharmacy preceptor. Today, we are going to go over F3, drug indication and pharmacotherapy knowledge, as well as F4, dosing knowledge. And we're doing both together because I don't think they should be separated. The indication and the dose of a medication go together. But let's go back a little bit. So far, we have done F1, know the drug name, the brand name, the generic name, the class, well enough to be able to carry them through a conversation. And we did F2, understanding the disease. You know what is happening inside the body and why. So now we're on F3 and F4. And again, I'm doing them together because they should not be separated. F3 is drug indication, knowing what a drug is for and why it is chosen for this patient. F4 is dosing knowledge, knowing how much to give and understanding that the dose is not a fixed number. It changes based on F3, the indication, the patient's weight, their organ function, and how sick they are. Pharmacology class teaches you drug as discrete entities. Here is a drug, here is the class, here's the mechanism, here's the dose. That works for building a foundation. But clinical practice doesn't present drug as a discrete entity. It presents a patient. It's complicated, comorbid, acutely ill, and asks you to look at everything that a patient is receiving and decide whether it makes sense. Not in the abstract, for this patient right now. What I have watched rotation after rotation is students who learn pharmacology well, but never made the leap from I know this drug to I can evaluate this drug for this patient. That leap from knowing a drug to evaluating it is what F3 and F4 are about. And as always, I'm going to illustrate this with a student story. The student and I were preparing to go up for rounds as usual. This patient was admitted with febrile neutropenia, a complication of chemotherapy. The absolute neutrophil count, ANC, was below 500. His body had almost no ability to fight infection on its own. Then he got to the medication list. Fluconazole for antifungal prophylaxis, ondansetron for nausea, filgrastim to stimulate white blood cell production, cefepime 1 gram every 8 hours. He wrote it down, said it out loud, moved right on. So I stopped him. Go back to cefepime for a second. 1 gram every 8 hours. Is that appropriate for this patient? He looked at his notes and he said, yeah, it looks reasonable. For febrile neutropenia, I insisted. And he said, let me look it up and get back to you. Well, let me tell you, for febrile neutropenia, the cefepime dose is 2 grams every 8 hours. The patient was getting 1 gram, half the dose his infection required. He didn't catch it, not because he skipped the medication list. He looked at the dose without connecting it to the patient and the indication. He saw a number. He didn't ask whether that number was right for this patient, for this infection, for this level of severity. So I asked him, how does cefepime work? He knew it was a beta-lactam. He knew it covered gram-negative organisms, including Pseudomonas. What he didn't know was that the dose for febrile neutropenia is not the dose for a urinary tract infection. And the difference is not a minor adjustment. It's double the dose. He knew the name, he knew the class, he hadn't learned the clinical logic that connects indication to dose, F3 and F4. When you see a drug on a patient's medication list, the dose is information. It tells you what the prescriber thought the indication was, how aggressively they're treating it, whether the patient's clinical picture was actually considered when that order was written. Febrile neutropenia requires aggressive coverage. The dose is higher because the stakes are higher. We corrected the order, 2 grams every 8 hours. We notified the team. The therapy was adjusted for the patient, and that was a pharmacist intervention. This is not a one-time thing. This was not just that one student. It's a pattern I have seen over and over and over. The students who list the medications without connecting them to the diagnosis. The student who sees a dose and accepts it because it's in the chart. The student who knows the general indication, but not the specific one. Not which infection, not which dose, not what changes when the patient's organ function or the severity of the infection changes the calculation. Every drug on a patient's medication list is there for a reason. Your job is to know that reason and evaluate whether the dose matches it. You cannot assume that the doctor ordered it correctly. A student who reads a list and moves on is doing a medication acknowledgement. And a student who stops, connects the dots to the indication, evaluates the dose against the clinical picture, and flags when something doesn't add up, that student is doing pharmacy. How do you practice drug indication and drug dosing? Before any rotation, I recommend identifying 20 to 30 most common medications in that setting. Learn each one of those drugs as complete drugs, not just the name, not just the class, the indication-specific doses, the major contraindications, the renal and hepatic adjustment thresholds. For weight-based dosing, know whether the calculation uses actual body weight, ideal body weight, or adjusted body weight. The wrong body weight in a vancomycin calculation doesn't produce a minor error. It produces a dose that is toxic or inadequate for this patient who is already sick. A drug like acyclovir uses ideal body weight for dosing, not actual body weight. So, know those things. For every renally clear drug, 3 questions before you move on. Does the patient's organ function require a dose adjustment? At what threshold? By how much? Build this habit now for every drug on every medication list. Ask 2 questions. Why is this patient on this drug? What is the indication? And secondly, does this dose match that indication? And as a pharmacist, when I work up patients, I always start with a medication list. Looking at the medication list, the drug names, the dosing, gives me an idea of what's going on with this patient before I even get into the chart and start reading the labs and start reading the doctor's notes. If I see enoxaparin 30 milligrams daily, I know this patient potentially has a renal issue that's causing renal dosing adjustment of the enoxaparin. If I see a patient on omeprazole or famotidine, I know there must be some kind of GERD going on or maybe GI prophylaxis going on. If I see enoxaparin weight-based, 1 mg per kg, or heparin infusion, I know there is a DVT, a PE, something in that regard. Know the drug, know what it's for, and know what dose should be used for those things when you're dealing with a real patient. Know the drug, know what it's for, know what the dose should be when those 2 things meet in a real patient. In the next video, we are going to go over F5, pharmacokinetics, because knowing the right dose for the right indication is one layer. Knowing what the patient's body does to that dose is the next one, and preceptors love you when you know pharmacokinetics. Subscribe now if you haven't yet. F5 is coming. Until next time, rookies.